Good morning. I'm Dr. Robert Greene. I'm MHCDS class of 2014, and today I have the pleasure of moderating this panel discussion on leading change. So this morning we'll focus on how leaders evaluate change opportunities and make difficult decisions. Our panelists have been asked to prepare an example of a significant decision they've made in the past year or two, and then discuss the salient issues. For maybe 7 to 10 minutes. I'm hoping we'll leave time for a discussion at the end. Today we're working on the beginning of the change process, how to make the decisions. Implementation and execution will be subject of other sessions. For the question and answer period, what we'll do, we're trying something a little different. I'd suggest that you use your cards on the table to write down ideas and questions during the presentations and the discussion, and then we'll take a 2-minute break and have you all put those questions and thoughts together. And Peter Curran will be going around the room, and we'll pick out, 4 or 5 tables. Unfortunately, happily, due to the size of the group, it will be a little difficult to get to everybody, but I hope we have a few good questions. Okay, so our panel members to my left, first Dr. Janice Nevin, who's the President and CEO of Christiana Care. Then Austin Pittman, MHCDS class of 2013, who is now Executive Vice President for Enterprise Healthcare Value at United Health Group. And Dr. Joanne Conroy, who is CEO and President of Dartmouth Hitchcock Health. So I've asked each panel member, as I said, to introduce themselves and give a brief description of the issue, the decision-making process, and the outcome of that.
Want me to go first?
Nevin?
Great.
Sure.
Well, thank you very much for having me here. For those of you who may not know, Christiana Care, we are located in Delaware. We care for people throughout the state of Delaware, as well as in Maryland, Pennsylvania, and South Jersey. We're a regional academic health system. And do that both through acute care, lots of outpatient care, home care, and I think have made the successful transition from hospital system to health system and really thinking very deeply about how we impact health. So I'm going to take a little bit of liberty with the question and maybe answer it a little bit differently than it was intended. But yeah, I've long been fascinated by resilience. I'm a family physician, so clearly from the experiences that patients have, some of my own experiences in my life, and I think resilience is a sort of a fascinating attribute to study, particularly as we're living in these times of extreme change. And so I remember reading a Harvard Business Review article in 2002 that really talked about resilience as a business strategy. And somewhere deep in the middle of the article, there was a brief discussion about organizations and how do organizations not only survive but thrive in times of uncertainty and change. And the author pointed out that it's not enough to have resilient people, but as an organization, you have to deeply know your values and you have to live those values consistently. And I was really struck by that. So about a year and a half ago, having been CEO of Christiana Care for a couple of years, sort of rolled out a new strategy, really reaffirmed our mission of serving our community. I said, it's time for us to think about how our values, let's take a look at them. What are our values as a system? What are the behaviors that we need to exhibit every day so that we can achieve the outcomes that we want, both for those that we serve and for each other? And I said, I want to do this work differently. I want to engage every single person that is part of the organization. I want to walk around at the end of the year, and no matter where I am in the system, I want to be able to have a conversation with one of our caregivers about how they took part in this work. And so we did that. So it was really a change in how we work as a system. The goal was to engage people, not only to build individual resilience, but to understand our organizational values. So we used a me, we community model. We did a lot of exploring of our personal values as well as our team values and ultimately our organizational values. And the senior leadership team had to engage in this work. If the senior leadership team, including the CEO, wasn't willing to have some of these more difficult conversations, we couldn't expect the others in the organization to participate and to change. So we did that. We had a wonderful consultant that helped us. We did a lot of work throughout the organization. We had 400 ambassadors, people who were not the usual suspects when it comes to leaders, who worked across the entire system to engage their colleagues. And after about 6 or 7 months of doing this exploratory work and bringing up ideas and having discussions around those ideas and then going back to the drawing board and recalibrating, we landed on a value statement. And that value statement is we serve together, guided by our values of excellence and love. We chose we serve together very deliberately. Teamwork had been a value, and when we did our work across the system, it's very clear that our people really love being on teams. But we were challenged because people love being in the team that they're, with the team that they're on, but we know that our teams weren't working effectively across the organization. So we serve together was really about let's create that structure where we're working together so that we can manage the changes that come our way. I wasn't surprised that excellence rose to the surface. We are an organization that is relentless in our pursuit of excellence in terms of quality and safety and experience and all of those metrics that we're constantly asked to report on. But the phrase I think that best exemplifies where we're going with excellence is a need to be exceptional today, but even better tomorrow. The word love, as you may imagine, caused quite a bit of discussion. What's love got to do with it when it comes to healthcare? It could be a song, yeah. And in fact, we use songs to get this out. But some really incredible conversation around the word love in healthcare. And I think the phrase that we use, it's really about anticipating deeply the needs of others and serving with compassion and generosity. I know I get letters all the time from grateful patients and families, and when a patient says or a family member says, I felt loved, the care that I received here made me feel like I was part of that nurse's family. That's very impactful, and that's really what we were striving for. And frankly, if you look at the literature, some of the work that Peter Pronovost has done, Don Abedian, the father of quality improvement, they both say, love is the sort of essential ingredient that is needed if you're going to drive your quality improvement work. So realizing that change is here, that we're living in times of uncertainty, for me and for Christiana Care and for all of our caregivers, it was really about doing the work to understand our values and behaviors and then deeply live them. And that's what we're doing now. So it has spawned a physician compact between our employed physicians and Christiana Care. We're embarking on taking $100 million of cost out of the organization, but doing it in a way that really honors our values of excellence and love. And many more examples of how we have used those values to make that work stick to really drive our organizational goals. So I will stop there.
Thank you so much. Austin?
Yeah, sure. By the way, I think you just hit on probably the most important thing about change right away, and that is the ability to actually move that organization is dependent on being really grounded in your values, your core belief in what you stand for and how you intend to go about doing it. That'll bridges those peaks and valleys of any business environment. And so if you really are going to manage change, it starts with that, in my opinion, certainly. So it's great to be with you guys. Great to see a lot of my classmates, my colleagues, my professors. Wonderful to be here. So you made it sound much more formal than my comments will be, but maybe a little bit of a description of United Health Group, just so you put this particular change opportunity in context. So we're just over a $200 billion enterprise. We operate both on the delivery system side, very significantly, work with probably 95% of all the hospitals in the country in various ways, as well as participate in physician groups, outpatient surgery centers, urgent care centers, you name it, that we're certainly engaged there, as well as then on the insurance side, you would know that as United Healthcare. Many of you, I know we certainly work with. The company that I most recently ran was Community and State. We take care of about 7 million Medicaid recipients across the country in 28 markets. And the particular change that I was going to speak to, actually, Rob, you were integrally involved, and that was the decision to change our entire clinical model. So we had previously really ran what I would call a very traditional, effective, but maybe not so much for our population, certainly community state, disease management type of mindset. So we had really great programs for diabetics. We had really great programs. You name the disease state, we had lots of really great programs. Problem was we had a lot of nurses sitting on phones calling people with really great interventions, but guess what? They actually couldn't find anyone. Right, so the reach rate, the number of times they actually got to people were really, really minuscule. Really great interventions, but they literally couldn't find folks. So based on a lot of good work, much of it actually came from the Camden Coalition, Dr. Jeffrey Brenner, who's actually now our medical director for Community and State, and many of you actually have participated with him as a professor in this program, we switched to a person-centered care model. Now, the reason that I started out with the size of the enterprise, imagine making the decision. We started with 3 pilots to test this theory out, to see if we could actually shift from a very telephonic, very nurse-heavy kind of disease management program into a community health worker, very diffuse, actually deployed very locally. And when I say locally, I mean actually in the neighborhoods, down to the street level, in homes. For a company that is about $40 billion in and of itself, taking care of 7 million people across 28 states. So no small undertaking. We ran the 3 pilots and really got to a place where, and I'll talk about this a little bit, got it to a place where it really became a no regret kind of move to actually scale this and scale this quickly. And that was that Rob was challenged with helping develop this model and get it to a place where it was cost neutral. So in other words, take all of those nurses that we were using on those phones, very, very great professionals, but reduce that staff, the nursing ratio, and start to deploy community health workers across the country and basically deploy this model that sounds like it would be incredibly inefficient, right? Very efficient to be in call centers, very inefficient to hire a bunch of people running all over the country in a bunch of neighborhoods and knocking on people's doors, literally to find folks. But the reality is we were able to do this at the same cost. And so it became a no-regrets move, and we moved very quickly from 3 pilots to scale. Rob, what was it, about 6 months that we scaled that completely up? So completely shifted the entire model within that period. Today, that patient-centered care model now has morphed into a whole-person care model, addressing the social determinants of care, housing, food. We actually purchased a transportation company, and it's still evolving that model very aggressively. But the moment at which and ultimately I had to make the decision, really was to say, you know what, we're not going to do any worse than we're doing today, for certain. We can only improve. We got it to a place where it was pretty cost neutral, and we knew we could find more people. There are several experiments that we had to do. One, how do you go hire 600 community health workers? How do you train them? How do you give them technology to actually run around in these neighborhoods and find folks and do care management plans and coordinate back? So there had to be technology developed. So that was the first experiment. Could you actually hire people, keep them employed? Oh, by the way, as a large employer, turns out we don't really hire people, many of whom are Medicaid recipients themselves previously, that might have criminal records that actually can go into these neighborhoods. So we actually had to challenge our entire hiring process and thoughts. In fact, to get around our own policies, we actually hired an outside firm at first to masquerade as us so that we could get around our own hiring policies. We did an awful lot of those things. Yes, I approved that too. And I'm still here. It's shocking. We do now actually employ folks, many of whom, again, are our former clients that have now are employed by United Health Group and actually reaching and performing this kind of work. Then we had to discover, could we actually find folks? So one, who should we be reaching? The top 5% of folks that drive 54% of the cost. So a tremendous amount of science, Dr. Greene, was deployed to really develop the algorithms to risk stratify our population so that we could actually find those folks. We got it wrong several times, but quickly iterated. And that was another decision point was, let's just get going, and then we'll rapidly iterate, and we'll figure it out. So can we hire folks? Can we find people? If we can find people, we'll decide over time what the right clinical interventions are to actually help them, and that's what actually led us down the path to the social determinants, because very quickly, as you all know, is you discover that you're not really managing just across a fragmented healthcare system. What you're really doing is managing across a very fragmented social services system. And that the reason that people were in the ER wasn't because the ER wasn't necessary, it was because they didn't have a refrigerator to keep their insulin cold. Their breathing disorder was really exacerbated because they didn't have clean air in their apartment. They had no air conditioner, and it was 110 degrees in Arizona, or worse yet, they were actually living on the street. And so we had to start to address those issues as well. And so that model continues to evolve today. But I'm incredibly proud that I think we've actually changed the entire landscape for United Healthcare, certainly in community state. And if you look at RFPs from states that are moving to managed Medicaid, we've actually changed what their expectations are of the healthcare delivery system itself. And so that was an incredibly important change, and I'm happy to say it's still ongoing. So I'll leave it there, and then we'll get into some conversation, hopefully.
Great.
Thanks, Austin.
Can people hear me in the back? I have a lavalier. Great. I'm Joanne Conroy. I'm the CEO of Dartmouth-Hitchcock and Dartmouth-Hitchcock Health. Many of you in the room are part of Dartmouth-Hitchcock, but you know we're the largest provider of healthcare in the state of New Hampshire and the second largest in Vermont. You know, when you posed the question, I thought about my career, and there have been a number of change efforts that I've participated in and or led throughout my career. But I think the bigger question is, how do you know when change is needed? And I spent a lot of my time scanning the environment, both internally and externally, and trying to look for people that are waving their arms, that they need help or they think something is not going well. It becomes a management failure for a leader to not pay attention to people within the organization that are identifying that something's not working. And that's really when you know that you're going to have to change how you either deliver care, how you structure your organization. And when that change ends up being really disruptive, and I've done layoffs, you know what? I think that's a management failure, that we haven't identified early enough that change was necessary. So when change has to occur, it feels much more disruptive than it really needs to be in terms of the culture and how the organization runs. So to answer the question about how do you know when you need change, you're constantly on surveillance for what things need to change. The second aspect, though, is that when you decide that something needs to be changed, what do you do about it? And I'd like to think in terms of three things. So there are three things, and you know, I think the first two you can decide what order they take, but I'm sure they're familiar to many of you. Is number one, we have to appeal to the hearts and then the minds of the individuals we're asking to change. I think with a lot of providers, we have to appeal to their mind first, but we can't forget that we actually have to make them emotionally committed to what we're trying to do. And that takes some time and effort to figure out where they are and how you actually shift their behavior. I can tell you at the organization I worked with in Massachusetts, we did a huge change effort around creating access in the organization. So we appealed to their minds by giving them data and demonstrating data on their no-show rate, their cancellation rate, basically the availability of their inventory that wasn't being used on a daily basis. But appealing to their hearts was a different challenge. How do you actually get somebody to understand that the more productive that we could drive the outpatient enterprise, the more safety and job security we would actually create within the organization. At that point, 78% of our revenue was from outpatient services. So when we didn't run our outpatient enterprise well, the entire organization felt it. And that's pretty unusual for healthcare, where often it's more in the 60% range. But I think the final piece that we don't always attend to is actually how do you make it easy? That's the piece about how do you remove the barriers, how do you remove the obstacles, how do you hardwire a change into how they do their work so they don't have to think about it. And if you don't do any one of those three, your change effort will stumble. And in terms of managing our outpatient inventory, I mean, we put it in the hands of our centralized call center that actually would overbook patients based on algorithms of historical no-show rates that we had for individual providers and actually across the clinics. So people didn't have to think about actually muscling additional patients into the schedule. We had actually used over 95% of all their available inventory on a daily basis. And that's how we actually really had a significant increase in outpatient efficiencies and actually created access for many of our patients who could get an appointment within 3 business days in a lot of our specialty clinics. I think that you have to constantly go back and make sure you're still attending to the hearts and minds. That means you have to give people data. You have to affirm to them that we're going in the right direction, and you have to constantly see how you can remove barriers within the organization. Now then, how do you make it sustainable? You just have to continue to have other reinforcing aspects of that be visible in the organization on a periodic basis that actually keep people engaged in the change.
Excellent, thank you. Okay, so I've been jotting down some notes, and I'm actually going to start with Austin for a moment because I'm going to come back to Dr. Nevin and Dr. Conroy and ask them to, especially Dr. Nevin, to give us a more specific example. I'm kind of a concrete person sometimes, and that helps me. But Austin, thanks so much for describing your involvement in the patient-centered care model, and it's great to hear how that's moved forward and evolved. Work on that was part of the work on that was my action learning project here at the MHCDS program. We were working to install behavioral health and social issues in primary patient-centered medical homes within an ACO.
By the way, if anybody needs to ask whether or not work from this program can impact change, I think we just described how it changed the largest Medicaid provider in the country, and oftentimes many of its competitors as well, because it really has driven a tremendous amount of change in the industry. So starting with that action learning project.
Absolutely, so terrific. It's just terrific to see. So here's the question I had for you as part of the change management. The things that you're describing, the community health workers are working at a very local level. And of course, United and even the community and state is a very large company. So how did you bridge that gap and bring people along at multiple levels to effect that change?
Well, so a couple of things. One, I mentioned technology. So just as a practical matter, we really did have to make an investment in new technology that was much more mobile, that enabled those community health workers to document in the field, that allowed physicians, nurses, both inside and outside of United, to share the same case notes, all of those kinds of things. So we did make a significant investment in technology. I mentioned the hiring process. I kind of made light of it, but in all seriousness, many of the folks, by the nature of what we needed them to be able to do, actually really didn't meet our minimum employment requirements. Or they couldn't pass a background check. We really had to challenge deeply our own hiring practices and say, what do we really want from the folks that we need in these marketplaces? That was a big experiment and an actual big change. And so if you also think about 500 some odd nurses employed in what people, again, in this business certainly look at and see as the most efficient way to do something. They're all in call centers. They can sit next to each other, share information, to challenge that whole process in an environment which is very nurse-centric. I mean, we tend to throw nurses at almost every kind of program. Oh, we need a new, right? We go hire a lot of nurses and we implement a new program. And so to challenge that with a whole new workforce was really hard. And so to really manage all of that change, myself, and it was a collective effort between United Healthcare and Optum, myself and a gentleman by the name of Dirk McMahon, who ran part of Optum, decided that we would personally drive that change. And so we began to meet on a weekly basis. We had rapid decision-making cycles. So as these barriers and all these arguments and discussions, very, very worthwhile discussions would come up, we would resolve them immediately, week by week, every week. And so it allowed the organization to develop a cadence and an inertia for change that really got us to a place where I think the organization we couldn't have stopped it if we wanted to at that point. It actually started to take on a life of its own and move up and down the organization very fluidly. So I think leadership is critical. I do think being grounded in what you're really trying to accomplish and how you intend to accomplish it, with the culture, with the values, and kind of keep coming back to asking some central questions about what it is that you're trying to do. And that enabled the organization to change itself, quite honestly, Rob. I think at the end of the day, we had plenty of science on our side. We had plenty of resources on our side, but the organization itself really began to believe in what we were trying to do and then changed itself.
That's terrific. Thank you for that story. And implicit, I think, in some of your comments is listening to the voice of the customer.
Absolutely.
Right? The patients and the
I was actually struck by what you said, and I think it actually is true. It actually starts with just listening. Listen intently. Not to hear what you want to hear or what you think you ought to hear, but just to listen and respond then from there. That's a big part of it. By the way, this has continued to evolve. One of the things that I think historically we've not done a good job of as a large company, even when we take on a big change, is we change and then we lock it down as if it's static. Like, we made the change, okay, we're done. And so quite intentionally from the get-go, this was we're not going to be done with this. We're going to keep evolving it, and enable the organization to think that way. And so that's why I say, even from when you left the organization and the tremendous amount of lifting that we did to get that change done, we've already iterated maybe 4 or 5 times over from there. And it's been really amazing to watch, particularly for an organization this size.
You know, Rob, though, a comment, and I heard it in your comments as well as Janice's. If you really are committed to change, I think we all have to ask ourselves, what's the frequency with which we're convening to both drive change and monitor the response? And then if you look at your calendars, if you don't meet every week about something that's really important to your organization, then it's not that important to your organization. And driving change, meeting every week, in Janice, in your efforts to really change the culture in the organization, that was probably more than every single week you were meeting and monitoring that. It's fascinating how, as executives, we say we want to change, but we meet about it every month.
Right.
And that's not going to make it happen.
And you know, that makes me think of something else. So to get in those weekly meetings, there's going to be some decisions on what not to do. And I don't know if either of you all would like to comment on that, because our schedules get so busy with everything, right?
Right. So I think we're not particularly good at creating we're not going to do this anymore list. although we are building on our values and behaviors work, we are in the process now of creating a new operating system for continuous improvement, really built on lean. And a lot of that is going to require us, frankly, both, again, from the level of the executive team all the way to front line, to spend our time differently, which means that we will be forced, I think, to find some things not to do. And I think meeting time is a great example. We've had a number of discussions at the senior leadership level, about meeting hygiene, and we just simply don't seem to be able to get a lot of it done, but I'm very optimistic. So I will share an example about a change that did involve something that we stopped doing. One of the things that, as the CEO, you don't want to be on the front page of your local newspaper, generally. It can mean only one of two things. Either you've done something really great, but they rarely want those stories, and more likely it's you did something and somebody's mad at you. So I had been the CEO for all of about 3 months. And prior to being the CEO, I had been the chief medical officer. When I was interviewed to be the CEO, I had made it very clear that our organization would be one that embraced population health, and that we were going to be building the infrastructure that needed to be built in order to deliver population health. And key to that is investing in behavioral health. We had a great track record as an organization of embedding behavioral health therapists into many of our service lines, but we had not yet taken the leap and actually embedded behavioral health folks into our primary care practices. So we made the decision, and it was a decision that had been in the works when I was chief medical officer, to essentially close 2 small legacy programs that served a very limited number of people in the community, but took up quite a number of resources, particularly the most precious resource, the people, behavioral health therapists. So we made a decision to close those programs, and unfortunately, the news of the closure leaked before we had time to really put a plan together to manage that. And then, lo and behold, we're on the front page of the News Journal. Christiana Care cuts mental health services, which was exactly the opposite of what we were doing. And so there was a lot of learning in that for me, learning a lot about the people and the support that we had in the organization. And frankly, I discovered that there were some significant gaps, both in terms of the external affairs capacity that we had and government relations, and so needed to fill those gaps. And I also learned that we had lost the opportunity to tell the story, which was really that we were going to deploy all of these resources into our primary care practices and do what I think is absolutely integral to delivering health, which is marry those 2 services. We would be adding substance use disorder specialists to practices, and we were going to train more behavioral health providers like psychologists, and we're starting a psychiatry residency. This summer we'll have our first class of psychiatrists. So the message completely sort of got away, and a lot of work to bring that back, but lots of incredible learning. Pleased to say we've got behavioral health therapists in all of our practices. We had to have the courage to keep going in that direction. There were a number of people in the organization who came up to me and said, I don't think we should do this. We shouldn't do this. Let's leave these programs alone. And that would have been the very wrong decision for the community and for the organization. So again, lots of good learning about when you go down a path, and it's a good decision, you have to manage that decision really well. But you also then, as a leader, have to give people the confidence that you've got their backs. This is the right way to go. We're going to do this. We're going to make this work. And it's worked incredibly. It's worked incredibly well. We had to accelerate the process. We didn't actually know how we were going to pay for it when we got started it, had to sort of learn that on the back end. But the fact that we were willing to actually do it and work out some of those details later was really helpful. About 2 years later, we got to be on the front page of the News Journal yet again for a very unfortunate episode of workplace violence. But I had incredible support from the external affairs team. I had a government relations team and a community engagement team that could immediately come into action. We had a good story to tell, and we started with "We're sorry." And made it very clear that this was not who we were as an organization. We were very serious about what happened. We were taking immediate steps to make sure it didn't happen again. And within 2 news cycles, the story was no longer in the media space. So 2 examples of change, and both, I think, sort of the good and the importance, again, of those values, behaviors, your mission, and having the courage to deliver.
Well, that's just terrific to hear those examples. And I'm going to come back to Joanne in a moment, but I want to switch gears just slightly because I was so fascinated, Janice, to hear your value statement of excellence and love. Because I was trying to think back at all the mission vision statements I've worked on over the years, and I don't remember it coming out exactly that way.
No.
How did that, as a touchstone, if you will, can you describe briefly just how that affected? I can imagine a lot of ways it affected the things you just described, but could you talk about that?
It was. I do believe that it was how we did our work that really had the most impact. Mm-hmm. And I did not expect that we would land with "We serve together, guided by our values of excellence and love." I fully expected that we would land with something that's a little bit more typical, which is generally 3 to 5 words. Mm. And so part of it was, I did not have a preconceived notion going into this. This wasn't, the CEO wants something, she's not going to tell us and make it look like we're all participating, but she already knows what she wants to do. I was very clear. I really didn't know. I didn't have the answer. I really wanted this to be about engaging our people. And we did that. And one of the most poignant moments for me was at the end of the year when we had a celebration for our ambassadors. I had one of our caregivers come up to me and say, "Thank you for letting me participate in this." He said, "I work in one of those practices. I didn't even think that you knew we existed. And now I know that you do." And so it's really that level of engagement that we can now build on. There's incredible excitement about love because it is so different. Even the physicians that when they were involved in the discussion were absolutely, you can't use love in healthcare. But when we rolled it out, the 2 of our surgeons, and you can guess the disciplines, basically stood up and said, "I was completely opposed to this when I first heard it, but I get it. I think this is great." And so again, creating that level of engagement has laid a foundation for us to do some of the really hard work that we're going to have to do. Everything we heard about in the first panel, it involves people behaving very differently, being willing to embrace change. I think for a great outcome, but getting the hearts and minds and providing people with the support and the understanding, absolutely critical to where we need to be.
Great, great. So one last question from me before we turn to the audience. So Joanne, hearing that description and knowing your emphasis on walking around and meeting people and having meals with people at the hospital and such, that strikes me as a combination of this voice of the customer and also engaging. And how has that affected the decision-making process? And could you give us some thoughts on that?
Sure. Well, it's really a component of surveillance. I'm not sure I would have appreciated the impact on our current benefit design on our employees unless you sit down with 7 people from engineering. We're going to tell you about the impact of the pharmacy plan and the high deductible plan on their lives. And they've been working for us between 10 and 35 years. So they took the opportunity to be very honest one Friday lunch. I had a breakfast with a number of employees, and there was a young woman who's an administrative assistant whose child is a 1.5 years old, and she says she's still paying off her delivery. So every single time she goes to make that payment, she says, my employer doesn't really care about me. And so those are really important things to hear because I get the financial piece of it. I was the chairman of a healthcare co-op in DC. I get all the numbers. I get, some of the decisions we made, but if you don't actually kind of get on the front lines and hear from people, surveillance in many ways, and then start reality checking it throughout the organization, then you identify things you need to fix. Do I think we need to roll it back? I think that's probably undoable from a financial perspective, but are there things we can put in place to really help components of the organization that are really adversely affected by plan design? That's what we need to do as an employer. I think there are other things. I just like to have my antenna up for people that are waving their arms. See, we're so polite. We don't wave our arms and say, this is a real problem. And then we don't attend to it. And then a few months go by and a small problem becomes a big problem. And then your change effort is just that much more disruptive. So I think, you just have to have a surveillance in many different ways and just constantly asking yourself, is this something that needs to be fixed? We can't fix everything, but we have to identify really the top priorities.
Great, great.
Can I just want to add one thing. I think that listening is most important, where you've got a dashboard, we've all created them, learned about them, all those things, and the numbers say one thing and the conversation says another. That, to me, that's the most valuable, is when is the discussion somehow not matching up with what my nice, neat management reports are saying is going on? And then that causes you to have to investigate and reconcile. Gosh, this says everything is really, really good. Change efforts on everything looks great. But then why am I having 10 conversations that suggest something very different is afoot than what that data suggests? And then reconcile that.
Right. Excellent. Okay, so as I said earlier, what I'd like people to do now is take a couple minutes at each table and collate your questions. That was the word I was looking for before. And I think Peter is going to wander around the room and see what people are thinking about, and we'll try to get as many questions in. We still have almost 25 minutes, so that's great.
How long do they have?
I'm giving you 2 minutes. We need the Jeopardy music.
I'm gonna go get some coffee real quick.
I can do that in 2 minutes.
It's good from working from your point. Okay. It's so nice to see the convergence of ideas.